So, pitter-patter heart, tiptoeing through one moment, galloping the next. All right, so I also cut down a lot of the history I talk about here, but I will keep this one little blip of Galen, our pal from the Roman Forum, the Roman gladiator physician. He was the first person to begin to map out with some level of accuracy, not full accuracy, but some level of accuracy, the flow of blood through the heart. He did believe, yes, it is a little off. What's up? Oh, what's up? That's not me. What is that? Huh. How do I fix that? There's something. Let's see here. Thank you. Look at that. Never. Is that better? That looks like it. Okay. So he believed that the blood emanated from the liver and was received into the heart through the inferior vena cava into the right atrium of the heart. And then it got from the right side of the heart to the left side of the heart through little pores that were both seen and unseen. We know that he was proscribed against doing dissection, but you can see here in Galen's depiction, the natural spirits are emanating from the liver, coming into the right side, and then the blood passes to the left through the wall of the heart, separating the right and the left side. Now, what's interesting about this, there actually is, at least in utero, a hole between the right and left side of the heart called the foramen ovale. Have I talked about that already? No, okay. Well, maybe I will here. We'll see what I have time for. But it's part of the fetal circulation of blood, which is a pretty interesting story. And then Leonardo didn't really evolve this very much. Did get a pretty reasonably accurate depiction of the vascular flow of the abdomen, however. So I'm going to give you two lectures. Lecture today, I'm going to go through the basic anatomy of the heart, the very basic anatomy, just enough to talk about the circulatory flow patterns, and then the cardiac cycle, the electrical conduction system. And then lecture Wednesday, I'll talk about cardiodynamics, what that actually means in terms of quantifying the blood that is coming out of the heart, the volume and rate of blood output, cardiac output. And I'll talk about how this is regulated with the autonomic nervous system. And then I'll talk about blood pressure a little bit and how that is regulated by the central nervous system and the peripheral nervous system. If I have time, I'll talk about heart disease. So the way things go with me, I probably won't get a chance to. We'll see. Okay. So let's jump to this, the superficial anatomy of the heart. Many of you have probably already had this in high school, I imagine, so I won't belabor it too much. But when you're looking at a heart, maybe when you find yourself in the cadaver lab or something in medical school, the first thing to do is to know whether you're looking at the anterior or posterior side of the heart. All right, so getting yourself oriented properly. And the heart looks a little bit like a dog's face. That's the way I think of it. We see here there's this right atrium in blue, and then there's the left atrium in red on the other side. And they have these little projections called auricle. Auricle just means ear. They do look like the ears of a dog, sort of flopping forward onto the anterior surface of the heart. That's how you know which side you're looking at. So you orient the heart so that the auricles are both pointing forward towards you. All right. And once you have that, everything else falls into place. So in general, this is a physiology class, but with anatomy, when you're trying to learn anatomy, the first step is to get yourself oriented and then get an anchor, an anatomical anchor that you can build other relationships off of. It's about anatomical relationships of one structure to another. So I find that orienting using the auricles is the right way to start with the heart. The great vessel that is most anterior between the two auricles is the pulmonary trunk. The pulmonary trunk is emerging. We'll see as we open the heart here. We'll see it's coming out of the right ventricle, and then sort of behind it and cradling it is the greatest of vessels, the aorta. This is the arterial outflow from the left ventricle. What else do I want to point out here? Well, a couple things that are interesting is this ligamentum arteriosum. You see that is pinning the aorta down to the pulmonary trunk. If I have time, I'll tell you an interesting story about that in conjunction with the foramen ovale. It's pretty interesting. And then, so I guess I should say first is that any vessel that is taking blood away from the heart, whether that vessel is carrying oxygenated or deoxygenated blood, is an artery. Arteries carry blood away from the heart. Veins carry blood to the heart. A vein is not necessarily deoxygenated blood. An artery is not necessarily oxygenated blood. The pulmonary trunk, for example, is an artery that is, or at least it breaks into the left and right pulmonary arteries, and that is carrying deoxygenated blood away from the heart to the lungs to get oxygenated. But it is morphologically and functionally an artery, regardless of its contents. The venous structure that is bringing blood back to the heart from the front, we see this superior vena cava bringing blood into the right atrium. To see the rest of the vasculature, we got to flip the heart over. So on this side, the auricles are pointing away from us. We have the right and left atrium, the right and left ventricle clearly labeled here, and the right atrium receiving blood from the upper extremity via the superior vena cava and the inferior vena cava from a lower extremity, upper extremity being arms, head, and neck, and then lower extremity just being thorax, abdomen, and legs. The left atrium receives oxygenated blood back from the lungs into the left atrium. So that's the right and left pulmonary veins, called veins because they're bringing blood back to the heart, oxygenated blood back to the heart. All right, let's look at the inside of the heart. We'll start on the right atrium, which is receiving the blood from the superior and inferior vena cava. Blood enters the right atrium, passes from the right atrium through the atrioventricular valve on the right side called the tricuspid valve. Cusp meaning tooth. It has three leaves, the tricuspid valve. And then from there, the ventricle will contract and eject blood out the pulmonary valve, pulmonary semilunar valve, out into the pulmonary trunk, to the lungs, comes back through the veins, pulmonary veins, into the left atrium this time. Passes from the left atrium into the left ventricle through the atrioventricular valve on the right side, which is called the also known as the mitral valve or bicuspid valve. Bicuspid because it has two leaves, and then ejected from the left ventricle through the aorta. All right, so a couple things I'll point out again. You see this this thing called the fossa ovalis, and that, along with the ligamentum arteriosum, are things that factor importantly into fetal circulation. I took the diagram of this out for the sake of time, but it's in the fetus, the blood enters from the umbilical cord into the hepatic system. It passes through the baby's liver first, and then returns to the heart via the inferior vena cava. This is actually oxygenated blood that it's gotten from the mother. But it needs to be disseminated, and we need to get it from the right side to the left side before it goes to the lungs. And the two ways that it travels are through this fossa ovalis, which is actually in the infant or the fetus, the foramen ovale. It's actually open, and then this ligamentum arteriosum is actually a duct in the fetus called the ductus arteriosus. So blood is able to pass through both of those. I'll talk about that more when we talk about hemoglobin in the respiratory chapter. Okay, so that's the basic anatomy. Let's look at a diagram of the circulation here. Again, blood. We'll just start with the right atrium. Deoxy blood is returning from the periphery into the right atrium, gets sent to the tricuspid valve. Ventricle contracts. The papillary muscles, which are the muscles embedded in the walls of the ventricle, contract, and the tricuspid valve is held shut. Blood is ejected through the pulmonary valve into the pulmonary trunk and the pulmonary arteries to the lungs, where it becomes oxygenated, returns via the pulmonary veins to the left atrium, and is pressurized in the left ventricle for ejection through the aorta, through the semilunar valve there, goes to the rest of the body. So there's really two vascular circuits in the body. There's peripheral circuit, which is or systemic circuit, which is most of the vasculature in your body, but there's also a pulmonary circulatory system that's on the right side of the heart, which is the job of which is to eject blood to the lungs for oxygenation. All right? Pretty straightforward. Yeah. Yeah. I mean, why aren't they the same shape? Why does one have three cusps and another? Well, first of all, the left ventricle generates a lot more force than the right ventricle. I cut some slides out, but I had some pictures if you want to see at the end of class, cross sections of the heart, where you can see the muscle wall of the ventricle is a lot thicker than the right ventricle. So that's going to have different fluid dynamics, and because of that, the valves are going to be slightly different. The basic functioning principle of them is the same. There are these leaves that have what are called corda tendineae, these cords that pull on the cusps, and muscles that hold them, which prevent them from relapsing. It prevents them from. So when the ventricle is contracting, these muscles that are pulling these the corda tendineae here and these papillary muscles are pulling down on the leaves when the heart is contracting and preventing the cusps from being blown back into the atrium. When that doesn't work very well, it's called atrial regurgitation or ventricular regurgitation. That's a problem in a person's heart. So the basic functioning is the same. Why this has three leaves and that has two. It has purely to do with the fluid dynamics of contraction there. Any other questions? All right. So that's the anatomy. On to the conduction system. So what's interesting about the heart is the heart rate is modified by central structures it can be attenuated or accelerated by the cardioinhibitory or acceleratory regions in the medulla, but that's not what initiates heart response, heart contraction. Heart muscle tissue is able to spontaneously depolarize. The heart itself is able to contract on its own without external prompting. And the origin of this is the cardiac conduction system, which is outlined here in purple. This initiates with the sinoatrial node, the SA node, which we see here right at the junction of the superior vena cava and the right atrium. From there are these internodal pathways that run throughout the myocardium of the atrium, throughout the muscle wall of the heart, and then converge upon the atrioventricular, or AV node. And the AV node is right at that boundary between the right atrium and the right ventricle. Then emerging from the AV node is the AV bundle, which then embeds itself into the interventricular septum. So this is the septum or wall between the two ventricles. The AV bundle gets embedded in there. These bundle branches emerge, and then they terminate in what are called Purkinje fibers. All of this was first mapped out in the mid 19th century by this famous guy here, Jan Evangelista Purkinje, who was a Czech scientist who's apparently so famous that he had colleagues in India and Asia that were able to, he would correspond with, and they could write, the only address they needed to write on the letter for this guy was just his name and Europe. And he was so widely known in Europe that just Purkinje, Europe, and the letter would get to him. That's something else. Anyways, the excitation that happens here throughout the heart is extremely rapid. It only is about 1 to 4 milliseconds. That's 1/1000th of a second. Very, very rapidly. Okay, so here's a picture of the cardiac cycle, an overview of the cardiac cycle, focusing on the conduction portion of it. It begins by electrical stimulus at the SA node. They spontaneously depolarize. This gets distributed along the conduction system throughout the heart. This is going to be what initiates the cardiac contraction of the muscles. And it is this electrical activity that's happening in the conduction system, which is what gives rise to what we call the ECG. It used to be EKG, cardio spelled with a K because the Germans were the first to develop this. But the ECG is like the little heart monitor, the blips. We'll talk about that in a bit. That's just looking at electrical fields that are generated by the heart in the conduction system. The cardiac contraction is what gives us our heart sounds, and it's what maintains our blood pressure and blood flow, of course. And then eventually the cardiac cycle, the heart relaxes, and we reset for another cycle of contraction. Okay, so that's an overview. Let's get into it a little bit. First of all, what's actually happening here? How come this is able to happen? So in a typical excitable cell, a neuron or a skeletal muscle fiber, we have a resting potential at the cell, right? So that resting potential is minus 70 millivolts. And typically the threshold for depolarization is minus 60. There'll be some sort of graded potential that happens because of a synapse on that cell, which brings the excitable tissue to threshold and causes an action potential. Okay? Well, in these myocardiocytes, the name that we use for a cardiac muscle cell, it's a little bit different. There is what's called a spontaneous depolarization. It doesn't need to have a graded potential to reach the threshold. There's a spontaneous depolarization that happens without the presence of a graded potential. And without trying to fit everything into the lecture today, without trying to walk you through the Socratic method of figuring it out in yourselves, I'm giving you the moment here to think and wonder why this might be. In fact, it's due to the expression patterns of leak channels. There are leak. So I said in the cell physiology chapter, I talked about the presence of all these different types of carriers and channels. Right? There's the sodium potassium ATPase that's throwing all the sodium out and potassium comes in. Then there are leak channels that are expressed in just the right proportions so that the cell is able to balance the activity of the sodium potassium ATPase and maintain a minus 70. Well, what's happening here is the sodium and potassium ATPase is constitutively functioning, but these leak channels are spontaneously depolarizing the cell. Then you hit the threshold, which is a little bit different in a myocardiocyte. It's only minus 40. You hit minus 40, you have an action potential, and the voltage-gated sodium channels swing open, then potassium swings open, and we get a reset sodium potassium ATPase going the whole time, but then the leak channels bring us back up to this threshold, and we have another contraction. Okay, so just a myocardiocyte is primed to be continuously contracting. All right, there's a continuous stream of contractions, and what really is going on, the ability to affect it, is the rate at which this happens. I'll show you a diagram of that in a moment. We'll see how that works in a little bit. All right. So let's go through the conduction process. Step 1, the SA node begins to spontaneously depolarize. The cells, the conduction cells in the SA node, reach that minus 40 threshold, and we begin to have an action potential there. This action potential, the stimulus spreads throughout the atrial surfaces in both the right and left side of the heart, and eventually is going to head towards the AV node. This takes about 50 milliseconds. Then, once it gets to the AV node, contraction begins in the atrium, and there's this active filling of the ventricles. So the atria are forcing blood down into the atrium. This is about a 100 millisecond delay at this point. AV node starts to fire up and sends a signal down the bundle branch, which propagates through the interventricular septum out to the to the bundle branches and the moderator band. The moderator band is a kind of a specialized papillary muscle that the nuance of which is not that important right now. And so this happens quite rapidly, only about 175 milliseconds. This impulse is distributed throughout the wall, the myocardium of the ventricles. Atrial contraction completes, and the atrium enter what is called diastole, and the ventricles enter systole, or contraction. We'll begin to contract there. So the AV valves, the atrioventricular valves, the bicuspid and tricuspid valves close, the ventricles contract, and blood gets ejected. All right, so all of this activity gives rise to the ECG. And here's a picture of what it looks like. You measure the ECG like this guy here with these little probes that are stuck on different places on the chest to pick up the electrical field. And different places are going to give you a report on different aspects of cardiac function. But they're integrated into a single trace that you see right here. This trace is broken into really three regions. There's a P wave, a QRS complex, and a T wave. A normal, healthy heart is going to have this P wave, QRS complex, and a T wave. The P wave happens when it's the initial phase of the conduction cycle, where there is depolarization at the SA node, and it's traveling through the atrium. Then there is the QRS complex, which is the big money here, where the ventricles begin to depolarize, and we get this large spike. And then finally, there's a recovery wave at the there's a recovery pulse at the bundle branches for the T wave. So analyzing the spacing between the PR interval and the ST interval and the QT interval and the QRS interval and the PR segment and the ST segment, all of these different minutiae of the timing and spacing and the relative ratios of these various time intervals are diagnostic markers, which you can learn about in your cardiology residency. Okay. So, are there questions? Am I going a little fast? I want to make sure I pack this in here. Well, I want to get to a certain point today. Okay, so the action potential. This is a picture of the action potential in a typical myocardiocyte. Now, it's a little bit different than what you've seen thus far. Prior to this, what were the two cations that were important for contraction? They were sodium and potassium, right? And indeed, sodium and potassium play the same roles here. Sodium is the trigger, and potassium is the recovery cation. So those play the same roles. But there's a third player that makes the action potential in a myocardiocyte different than you would see in a typical skeletal muscle fiber. And specifically, this is calcium. Calcium is what's called the Plateau ion. So we have threshold here. We have rapid depolarization, and potassium is going to cause a repolarization. But before we really do that, calcium ions are working against the potassium ions to cause a long plateau of depolarization, And the result of this is to stretch out the absolute refractory period for a long period of time, much longer than a skeletal muscle. So if we look here, at the top is action potential of a skeletal muscle versus action potential of a cardiac muscle. We see an action potential of a skeletal muscle is very quick with short refractory period, whereas cardiac muscle, the action potential is very long with a much longer refractory period. The result is in a skeletal muscle, the contraction of that skeletal muscle cell falls outside of the absolute and relative refractory periods of that skeletal muscle cell. The contraction, the actual tension that is generated by that skeletal muscle is outside of the action potential window in that muscle cell. Whereas here in the myocardiocyte, because there's such a long window of refractory period, the actual tension and contraction that's happening in the myocardiocyte falls within that refractory window, period window. So that muscle fiber is actually able to relax before it's forced into another contraction. The upshot here is that in a skeletal muscle, we can have tropez and wave summation, and we can reach a tetanus in a skeletal muscle fiber. But you are not able to reach tetanus in a cardiac muscle fiber. You can't have wave summation in a myocardiocyte. And this is a good thing. You don't want your heart muscle to go into tetanus, right? You don't want your heart muscle to be contracted and unable to release. What you want your heart muscle to do is contract and release and contract and release and contract and release in a coordinated cyclical manner, because the job here is not about the maximum load you can lift, but it's about the pumping action of the heart and being able to move the maximal amount of blood. Does that make sense? to you guys? So the third ion that is of importance here is calcium, and it's the Plateau ion that is preventing the recovery from happening immediately after the depolarization. Questions on that one? How you guys doing? Good? Most of you look pretty alert. Okay, so let's go to the cardiac cycle. A couple definitions first is systole and diastole. I've been using these terms. Most of you probably know them already, but systole simply means the contracted state of one of the chambers, whether it's the atrium or the ventricle, and diastole is the relaxed state of one of the chambers, either the atrium or the ventricle. Atrial systole and ventricular systole do not have to be, and they are not, in fact, concurrent with one another. All right, there is a staggered pattern of systole and diastole across the chambers of the heart. So this is just an overview. Let's go through the overview, and then I'm going to put up a diagram that puts a lot of what we've talked about together, which will be sort of the whole point of the day here. So at the start here in the upper, at about 11 o'clock at the upper left-hand corner there, we have the beginning of atrial systole. So the SA node has depolarized, and the signal has spread out through the internodal pathways to the AV node, and the atrium now is beginning to actively contract. It's actively pushing blood out of that atrium into the ventricle. Up until this point, it's been passive filling of the ventricle, basically driven by what's called the preload, or the venous blood pressure. What's the blood pressure of blood that's returning to the heart? That's what's helping to fill the ventricle. Atrial systole will, after about 100 milliseconds, ends, and the diastole begins. It's now relaxing. And ventricular systole, first phase begins. There's two phases to ventricular systole. The first phase is when the ventricle begins to contract and pressure begins to rise rapidly in the ventricle, but no blood is being ejected yet. It's working against, so we have contraction here, but it's working against the blood pressure in the pulmonary and aortic circuits. All right, and it hasn't. As soon as the pressure here matches these, then we move on to the second phase of ventricular systole, where the blood now pressure in the heart exceeds that of the aorta and the pulmonary trunk, and blood is able to push its way open and past the semilunar valves, the aortic and the pulmonary valves, to enter those vessels. Blood is ejected, and then we go through a pressure wave that will eventually drop off, and the back pressure from the blood, we call that afterload, then pushes these semilunar valves closed. They snap shut, and then we're going to begin, ventricular diastole begins, and we move on to the passive filling of the atria and the ventricles from the preload, the pressure of blood in the venous system. Okay, does that make sense? I've walked you through that on sort of a mechanistic basis. All right. Wow, I went faster than I thought. This is my last slide I was planning to talk about. Okay, so this slide here is sort of the culmination of the whole lecture. It brings everything I've talked about into a single slide, and I suggest that you familiarize yourself with it. So on the x-axis is time, all right? And I have several, and so everything's synced up along the x-axis in terms of a single cardiac cycle, all right? And I have the various observables here. On the top is the ECG, which gives us an insight into the electrical conduction pathway and the events that are happening there, the P, the QRS, and the complex, and the T wave. Below that, I have a description of the systole and diastole events in the atria and the ventricle. And then down here in this panel, I'm showing pressure in millimeters of mercury for the aorta in black and just the left side of the heart. So the left ventricle and the left atrium. So this is just looking at the left side of the heart, not focusing on the right, but similar sort of thing would be happening on the right side of the heart. So at the beginning here, at step 1, so all these numbers are laid out here, but at step 1, you have the beginning of atrial contraction, atrial systole, you see there, and that corresponds with the P wave. Right? So we have the contraction of the left atrium, the pressure goes up, and the pressure in the ventricle matches that, right? Because we are now having active filling of the ventricle from the atrium. AV valve closes as the conduction reaches the AV node, and we begin to have ventricular contraction. We're going to enter ventricular systole right now. And this is coincident with the QRS complex. So the AV valve, the mitral valve, the bicuspid valve, all the same name, shuts, and we enter the first phase of ventricular systole, where the pressure begins to skyrocket. But in this first period, it is still lower than the aortic pressure. The aortic pressure is the so-called afterload. It's the pressure against which the heart has to work to eject blood during systole. So the pressure of blood in the left ventricle has got to reach the pressure in the aorta before it can open up those doors. That happens, and then the aortic semilunar valve opens up. Blood is ejected from the ventricle into the aorta, and the aortic pressure goes through a peak. And this is a ventricular ejection. And then eventually, the semilunar valve is going to close. All right? And the pressure begins to drop in the left ventricle, and the aorta has the pressure of the ejected blood. Now you'll notice here, so this, if you were taking a blood pressure, when you take someone's blood pressure, is that just a single number? No, it's two numbers, isn't it? There's the diastolic and the systolic pressure. The systolic is on top, and the diastolic is on the bottom. That's what these are. So this would be your systolic pressure, and this would be your diastolic pressure right here. No, pardon me. This is systolic, the peak. Pardon me, that was a mistake. The systolic pressure is up here, and this is your diastolic pressure. That was a misspoke. So this person's blood pressure is about 125 over 80. That's a reasonable, healthy blood pressure. A little bit higher than mine and many people, but that would be like a common, healthy, middle-aged blood pressure. So then on the bottom here, this is volume. And this is going to be important. We're going to need to understand the volume of the heart, because this is going to help us understand the concept of cardiac output. Cardiac output is going to be pretty much the topic of conversation for the whole class on Wednesday. So at the beginning, so this is just looking at the left ventricle, not the atrium now, just the line in red, the left ventricle. We have this point here where there's passive filling. The volume of the ventricle is filling just by virtue of the back pressure from the venous blood pressure, the preload. So this is this preload. This is the end volumetric pressure that's going to stretch that ventricle. How much blood is returning to the heart? What's the pressure of that venous blood that's coming back? That's giving us a passive passive filling of the ventricle. We enter atrial systole, where the atrium is beginning to contract and force all the blood that's in the atrium into the ventricle, so it's now in active filling. The ventricle stretches as it's filled actively with blood, and we reach this volume right here. We call this the end diastolic volume. This is the volume in the ventricle at the end of ventricular diastole. So right before the ventricle is about to contract, how much blood is in it? That's what's important, right? Because the amount of blood that's in the ventricle right before it contracts is going to be obviously directly related to how much blood the ventricle is able to eject. So the first important point here in terms of blood volume is the end diastolic volume. We go through contraction here and it's ejection, ejecting all the blood. The volume of blood goes down until we reach the end of systole and the beginning of diastole, right around here. This volume that's left in the heart, in the ventricle after ventricular contraction, we call this end systolic volume. All right? The difference in end diastolic volume and end systolic volume is what we call stroke volume. That's how much blood per stroke of the heart, per contraction of the heart, was the heart able to push out. That stroke volume. Cardiac output, basically said, is simply the product of stroke volume and your heart rate. How much blood is your heart pushing out per beat, and what is the speed of beats that your heart is going at? That tells you how much blood per unit time, blood per minute, that your heart is pushing out. Stroke volume. So there is, you'll notice here, a reserve volume. There is a little bit of a reserve volume. There's an amount of blood in the heart that does not get ejected, right? It's not able to completely collapse on itself. But the stroke volume is the amount that's actually pushed out for each contraction. Then at the end of systole, the ventricle enters diastole, and we get passive filling. So both the ventricle and the atrium are in diastole. The heart is at rest right now because we're in the middle of that long calcium-induced refractory period. All right, this is where we have the calcium plateau during this point. The chambers are passively filling by virtue of the preload, the venous pressure coming from on the backside of the heart, until we reach the myocardiocytes have been reset, the potassium channels have reset, and the heart is able to the SA node is able to depolarize, and we go through another contraction cycle of the atrium, and we get the active filling once again. Okay, so all of this activity gives rise to the heart sounds that we hear. So the lub. So you ask most people to describe what a heartbeat sounds like. I could ask my 6-year-old daughter, and she would say, bump, 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 bump. That is the lub and the dub that people are so familiar with, the lub dub, dub. There are actually two other sounds. So lub is the S1, S2 is the dub, S3 and S4 are some other attendant sounds. The S1, the lub, is the sound of the aortic valve snapping open. That's the lub. Is those the aortic and the pulmonary valves, the semilunar valves, snapping open, and then the dub is the sound of that same valve snapping shut. When you get to the cadaver, has anyone dissected a heart before? Yeah, okay. When you were in there, it was like a cow heart or a pig heart or something. Yeah. The AV valves, the dicuspid and tricuspid valves, they're papery. They're super thin and flimsy. But the aortic valve and the pulmonary semilunar valve, they're actually quite cartilaginous. They kind of snap a little bit. And that's what gives rise to these sounds. Much like, they're cartilaginous, much like the cartilage that's holding your eustachian tubes closed. When you open your jaw, you can hear that crack in your jaw. That's the cartilage in the eustachian tube snapping open. In a similar way, the cartilage of the semilunar valves snaps open and gives us the heart sounds that we hear. Are there any questions about this? All right. So I have a minute here. So why don't I begin to just, this is where I was going to start next time, and I'll just preface it today to make it easier next time. So all of this can lead us to cardiodynamics, and that is simply a study of the movement and force generated by the cardiac contractions. The important terms here are end diastolic volume, which I just defined for you as that volume that's in the ventricle at the end of diastole, right before ventricular contraction, and then the end systolic volume, which is how much blood is left in the heart after the ventricle has contracted. This difference is called stroke volume, and the units on stroke volume are simply milliliters per beat. How many milliliters per contraction or milliliters per beat did the heart go through? A term that you often run into in medicine is ejection fraction, and that's simply the percentage of end diastolic volume that stroke volume represents. Is that a 60% of the total volume of the heart, 80%? What is that ejection fraction of the heart? And lastly, cardiac output, as I'd already said, is simply the product of the stroke volume and the heart rate, which gives you the total volume of blood pumped by the left ventricle in a minute. We'll revisit this slide on Wednesday, and I'll finish up with the heart then. 30 questions? That was a whirlwind tour of the contraction of the heart.